starting with how do we treat a patient that shows up that is accidentally ingested. So I do recommend having a read through that and as we go into further discussion. So first step is taking that ever important history, right? What did they get into? How long ago and how much? Right? They may think that their animal has gotten into one substance. They might think that that's a pure substance. There could be other additives in there, things like caffeine. Okay, that's going to make it much more dangerous for our patients who are very sensitive to caffeine. I discuss owner intoxication, and so if the animal got into something, is there a chance that they had it out because they were also using it as well? This could be a little bit more tricky, a more sensitive situation. Ideally, having a veterinary social worker, if they were on staff, would be a great person to have introduce into the conversation. Then, of course, your physical exam, right? Going from head to tail, looking at their demeanor, their neurological status, looking at their CRT, their perfusion rate, like getting an auscultation, temperature, kind of our basics. So urine drug screens. So should we use them? Should we not use them? I'd say if you have them, if they're available, go for it. Then this might give you a little bit more information. Was it, potentially inhaled or insufflated as well? That's maybe going to change your approach, and vomiting is not going to be appropriate there. From there, as part of a regular decontamination protocol, we would, in the ideal situation, go into whether activated charcoal is going to be proper or not. For a lot of use, I wouldn't be rushing to give activated charcoal. I am not sure about the binding of, say, LSD, MDMA. I don't think charcoal is going to make too much of a difference. And the biggest takeaway is that pet stable. Then I would say go for it. If they're not, then I would be a little bit more cautious and treat the symptoms or treat the patient as they are. This is, let's say, past the decontamination period, and I'm going to say we're seeing more adverse effects, okay? Or what could potentially be discussed as, a bad trip or a dysphoria, as we often see in anesthesia in our veterinary patients. But what's important is to be able to distinguish this dysphoria versus serotonin syndrome, which we'll go into a little bit more detail. I think serotonin syndrome is kind of the biggest thing that we have to be worried about, either when interacting with other drugs or if given enough of a specific psychedelic, especially MDMA, where serotonin syndrome could actually be a risk. So, and this is taking some more research. I'm finding some conflicting information of using diazepam in some situations, not in others, and phenothiazines as well. And so this is what I'm coming up with. Diazepam, I would generally regard as safe in most procedures. Diazepam is commonly used in human, let's say, in those field situations or recreational situations where they often have MDs involved. I know that diazepam is commonly used for people who are at festivals. And it's important for us to know here that we're taking in often people who are sleep deprived, not eating, people who are having multiple substances over several days, and that diazepam, while it's not primarily used to interrupt their trip, they will use if a person seems necessary. Now, this is a little bit controversial in the therapeutic setting where you want people to go through maybe that difficult part of it, and giving diazepam for some people is unethical. But I don't think as veterinary practitioners we have to worry about that too much. Our priority is going to be my patient. I wouldn't hesitate to give diazepam if I thought the patient was dysphoric. Okay, just like with anesthesia, I would reach for diazepam. Phenothiazines seem to be recommended as well. So acepromazine or chlorpromazine can be reached for. I would be more concerned if we're reading some reports, is this going to potentially lower the seizure threshold? And I always, for multiple years in anesthesia, hear back and forth reports of this, but something to be aware of. So a little bit of caution there. Cyproheptadine, okay, this is a serotonin antagonist, so this actually seems to work quite well, and I've heard of it used in mild cases to prevent serotonin syndrome, or where serotonin syndrome is actually occurring. Cyproheptadine can be helpful. And if there's any contamination, like we said, either suspected with naloxone, if there's any opioid interaction or any fentanyl, anything like that, that's potentially within the substance, then naloxone is going to be a great help. I put CBD here as well. I haven't found too many reports of CBD actually published in humans being able to bring down anxious or difficult trip. But I think we're finding, at least with high THC exposure, that CBD can be quite calming. And so we're seeing anecdotal reports or people discussing using CBD, pure CBD for calming in bad psilocybin trips or mushroom trips or LSD trips, but there's not too much other. So it's one that I think warrants some discussion and could be, a great opportunity there. Atropine, no. And so this was interesting. Dr. Cassara and I were just discussing before this, and this is more related to Amanita muscaria, which I haven't gotten too much into this week, but I think something we'll definitely jump into a little bit more in the future, given that there's increased exposure in dogs. Dogs can find them on their own and eat them. And there have been fatalities related to Amanita muscaria, and well, Dr. Casares was hearing that it was potentially diazepam related. I've been hearing it's potentially atropine related. Given that atropine can have an anti-muscarinic effect, is it something that could work? Potentially no, and can actually exacerbate symptoms. So one, either of extreme caution or to be greatly aware of in Amanita specifically. It is critical to obtain an accurate history in order to gather information about the animal's environment, amount of exposure, time from exposure to onset of clinical signs, as well as type, severity, duration of clinical signs. So that's all I have for today. And feel free to reach out if there's any questions that you want to bring up outside of this or any concerns. Please let me know. I'm always happy to chat about that.